person to show us the first, the presentation by Francis Dumba. Let's have it on the screen. Francis Dumba's varied prevalence of antimalarial drug resistance markers. Okay, that's it. So you're Francis? Okay, just have a seat. So colleagues, this session is on antimicrobial resistance. The chairs are myself, Fred Kitutu, standing in for Dr. Henry Kajumbura, who is the chair of the National Antimicrobial Resistance Subcommittee of the One Health Platform. A few remarks about myself. I'm a senior lecturer in the Department of Pharmacy at Macquarie University and a pioneer focal point for the antimicrobial stewardship, optimal access and use technical working group of the One Health Platform, Ministry of Health, MAIF, Ministry of Water and Environment, Ministry of Agriculture, Animal Industries and Fisheries, and an active member till then. My background is pharmacy, so I'm interested in antimicrobial resistance as a driver of antimicrobial resistance, one of the top 3 threats that we face as humanity, affecting both health and sustainable development. And we need to do everything we can to reduce its effects, to make sure that organisms do not run away from the current treatments that we have. So with that, I'd like us to get into the first presentation, where we are going to hear the different aspects of AMR, its burden, the drivers, and some of the solutions as presented by our researchers. Our first presentation is focusing on malaria, which is responsible for substantial disease burden and mortality in Uganda. But they are looking at resistance. Francis Dumba will introduce himself briefly before getting into the presentation. Francis, you have 8 minutes. You're welcome to the podium.
Thank you very much. Good morning, everyone. My name is Dumba Francis Semakuba, and I work with Infectious Diseases Research Collaboration, and I am a laboratory technologist. Okay. Good morning once more again. My name is Dumba Francis Semakuba, and I work with Infectious Disease Research Collaboration, and I'm a lab technologist. Yes, today I'm going to talk about antimicrobial. Shall I start? Okay, thank you. Today I'm going to talk about antimalarial drug resistance in different populations of newly arrived refugees in Uganda. So to give a brief background about this study we had, emerging antimalarial drug resistance threatens the malaria control in Africa. And malaria molecular surveillance has enabled early detection of these resistances before they are widely spread across the continent. However, conflicts and instability in various areas of the continent makes it hard for us to carry out routine malaria molecular surveillance in these areas. Identifying simpler, safe, and effective means of being able to carry out malaria molecular surveillances on populations originating from such areas will be very important to mitigate the effects of resistance. Studying the refugee populations generates information about the drug resistance of these of the refugees from their countries of origin, and also generates information about the malaria state of these populations that are residing within the country. So the study was aimed at evaluating the prevalence of Plasmodium falciparum antimicrobial resistance markers in newly arrived refugee asymptomatic children in Uganda from the Democratic Republic of Congo and South Sudan. Okay, thank you very much. So to give a brief background of our study, Our study was a cross-sectional study that was carried out at 2 refugee reception sites. That is Adjumani reception site that receives refugees from South Sudan, and Changwali reception site that receives refugees from Democratic Republic of Congo. During our study, we surveyed children that were between 0.5 years to 10 years, and these children should have arrived within the country within 7 days. During our study, we collected blood samples. For these blood samples, we had to prepare a blood smear for microscopy. Then we ran RDT, rapid diagnostic tests, and then we also stored the blood sample on a DBS card for other molecular testing. And during the study, we did the parasite identity, determining the different species using a nested PCR. Okay, and we did sequencing using molecular version probes. So during our study, we determined and we found out that the parasitemia percentage at these different populations was high. As you can see, there is 36.4% and 28.5% at Adjumani for both RDT and microscopy, and then 67.1 and 44.9% at Changwali for both RDT and microscopy respectively. We found out that most of these infections were caused by Plasmodium falciparum. The other species appeared as mixed infections for Plasmodium falciparum with malaria and Plasmodium falciparum with Plasmodium ovale, as you can see on the graphs on your right. And we saw that Plasmodium malaria with Plasmodium falciparum was the most predominant infection, and it was seen in Changwali. So when we went ahead to look at our drug resistance markers, when we looked at drug resistance markers that are associated with artemisinin resistance, that is the K1367V and the K13469Y, we saw that there was a higher prevalence in the Adjumani site compared to the Changwali site. And then when we went to the ones that are associated with chloroquine resistance, that's the CRT76T, still Adjumani had a higher prevalence compared to those in Changwali. And when we went to the ones that are associated with amodiaquine resistance, that's the MDR1N86Y, the prevalence was also higher in Adjumani. And we can see in Changwali there is a very low prevalence. And just to give a brief review is that in the Democratic Republic of Congo, the first-line drug of treatment is AL. And normally, the wild type, which is N86, is normally selected for in an AL pressure compared to the mutant. So that's why we are seeing a very low prevalence. And then when we went to the ones that are associated with SP resistance, that is the DHFR164L, that one confers higher resistance to piperacillin. It was higher in Changwali. Then the DHPS581G, it was higher in Changwali, which also confers a higher resistance to sulfadoxine. So this is a threat to our intermittent preventive care in pregnancy. So in conclusion, the prevalence of Plasmodium falciparum associated mutations, both towards artemisinin partial resistance and antifolate, was high in these refugee populations. But still, these mutations varied between the different populations. As we can see, South Sudan had higher prevalence of artemisinin partial resistance and also higher prevalences of chloroquine mutation resistances. And then DRC had higher in other prevalences in antifolate resistance. Our data has offered important information on the patterns of antimicrobial drug resistance mutation in those hard-to-study areas. So our data also indicates a substantial prevalence of malaria infections in the different populations of the refugees. Okay, sorry about that. So our limitations of the study, we had a limitation of the sample size because we just took up a modest number to do a testing. And then we don't have specific information on the different regions. So this is like taking the whole DRC or South Sudan. So we need to do more studies that pick out specific regions in these different countries to get a clearer pictures. So the implication is we think if they add routine malaria surveillance on the newly refugees that are coming, especially for the drug resistance, we can be able to keep up with these mutations and how they move around the different countries. Then also targeted malaria drug policies should be implemented because there's a difference in the mutations, like for South Sudan and in the Democratic Republic of Congo. So thank you very much. My time is done.
Thank you very much. You can take your seat. Again, a round of applause for Francis for taking, keeping within the time. Our next presenter, Abdul Alusasa. Are you here? Yeah. If Abdul is not here, we shall move to the next, who is, sorry. So let's have Robert, Dr. Robert Onzima Anguyo's slides up, IT. The IT, can you come and demonstrate how this works so that, is it the green? Okay, thank you. So yes, our next presenter is here, and the topic is using road quality assurance sampling on for local surveillance of AMR and quality of healthcare among under 5. So you just use this to go forward and this to go back, and just make sure. You have 8 minutes.
Thank you, Chair. I'm sharing on using load quality assurance sampling for surveillance of quality of healthcare and antimicrobial resistance prevalence in decentralized settings. And this is a multi-country study that we conducted in Uganda, Malawi, and Zambia. But I'm presenting preliminary proceedings in Uganda. In Uganda, we have Doctors with Africa, QAM, from where I come, and the Makerere University School of Public Health and College of Health Sciences as the in-country partners for this study. I won't waste a lot of time in the background because we already know the extent to which AMR has become a big problem. If unmitigated, is projected to be directly attributable to about 10 million deaths by 2050, of which close to 90% of these deaths are expected to be in Sub-Saharan Africa and Asia. So the key driver of AMR is antibiotic use and misuse. And one compounding challenge is that there's no affordable approach for which we can employ population-level active surveillance of antimicrobial resistance. As a result, we undertook this study to try to address this. And our response aims to develop a metric that can be used as a basis for antimicrobial resistance surveillance in decentralized settings. And the study has about 5 objectives, of which objectives 1 and 2 are the ones I'm focusing on in this presentation, where we aim to develop a rapid recurrent surveillance system for antibiotic use and antimicrobial resistance prevalence, and investigate the association between quality of healthcare and antimicrobial resistance, and further use the data to assess the risk of development of resistance by analyzing genomic traits and future emergency of resistance. Our methods, we are adopting the load quality assurance sampling for classification of AMR prevalence in urban, peri-urban, and rural contexts, where Gulu City represents our urban, Gulu district represents the peri-urban, and Lamo districts represents the rural. And then we undertake microbiological analysis of nasal and rectal swabs for methicillin-resistant staph aureus and extended spectrum beta-lactamase producing Enterobacteriaceae in order to make classifications of the level of resistance. Our sample size was developed using this model, which looks at 20% as our higher threshold for resistance and 5% as the lower threshold for what is considered as the acceptable level of resistance. And using that model, this is the resulting operating characteristic curve that gives us a minimum sample size of 44 and a decision rule of 5, where our alpha and beta errors seem to meet our model criteria at the minimum sample size that we have. But in actual sampling, we did sample 6 febrile under 5s from each selected health facility, giving us test samples of 6 each in each of Gulu City and Lamo district, and Gulu City and 72 in Gulu district. We then validate these test samples using a larger sample sizes, as we see in the presentation. As I said, we targeted febrile under 5s. We assess quality of care through clinical observations, exit interviews, healthcare facility observation, and health worker interview. And then we assess antimicrobial resistance through nasal swabs for MRSA and rectal swabs for ESBL producing Enterobacteriaceae, targeting ESBL E. coli and ESBL Klebsiella pneumoniae. Analysis of the data, we focus on 2 areas. One level, we are making district level classifications using LQAS with tailored to the actual sample size that we obtained, giving us decision rule of 7 for each of Gulu City and Lamo district, and a decision rule of 8 for Gulu district. What did we find? These are the characteristics of our respondents. I'm not going to spend time on that. Let me go direct to our classifications, which found a high carriage of ESBL producing E. coli across each of the 3 study districts, exceeding the threshold of 20%. And we had mixed findings regarding ESBL producing Klebsiella pneumoniae, where Gulu City seemed to have a low prevalence, and then Gulu district and Lamo, Gulu district had a low and Lamo district had low, whereas Gulu City had high carriage of Klebsiella pneumoniae among the febrile under 5s, whereas for MRSA it also happens to be the reverse. We assessed association between quality of care and AMR, and quality of care when we looked at the children who have had carriage of the bacteria of interest. Quality of care generally appears to be a preventive factor, but whereas when we looked at the overall sample of children, including those not carrying the bacteria of interest, we seem not to be seeing an association. However, the associations, though not statistically significant, appear to show that where quality of care was high, there appears to be an increase in the odds of resistance. Here we only focused on multi-drug resistance in ESBL producing E. coli. looking at the health facility level assessments, we found that presence of guidelines for disposal of expired drugs was associated with a reduction in the odds of multi-drug resistance. And then our final model seems to continuously show that quality of care depicted through following IMCI procedures at the health facilities appears to be preventive to emergence of multi-drug resistance. However, assessing for one symptom has shown a reverse direction in that it is associated with an increase in multi-drug resistance. So what did we conclude? Our LQS classifications show variation in coverage of resistance across districts. However, there was consistency that ESBL producing E. coli had high prevalence across all these study districts. Good quality of care appears to be associated with a reduction in reduced odds of multi-drug resistance in ESBL carrying E. coli, and the presence of guidelines at facilities was associated with a large reduction in AMR. Our next steps involve validating the load quality assurance sampling approaches, genomics works and evolutionary biology, and community level assessment of drivers, and finally, stakeholder engagement. Thank you.
Thank you very much, Dr. Nzima, for presenting a very interesting case for LKS and for keeping within time. Our next presenter is Mansoor Ranjaba, and you'll take 30 minutes to introduce yourself. You have 8 minutes, and we'll signal when you reach the 5-minute point and the 1-minute point. In terms of using this, please come ahead. So this is forward, but you position it there. And then grade is back. But the position is important.
Good morning, colleagues. Good morning, ladies and gentlemen. I'm Dr. Mansoor Ranjaba. I'm working with WHO as Senior Advisor of Malaria and Neglected Tropical Disease and Vector-borne diseases in Uganda, Tanzania, and Eritrea. The article that we are going to present with my dear colleague, Dr. Morin from Ministry of Health, is a joint publication of WHO and Ministry of Health. And actually, Dr. Morin is going to present. Just I am here to have an introduction regarding the importance of the project. The project is actually, it is a prospective project. It covers 3 parts: situational analysis of the case management, malaria case management in Uganda, and drivers of malaria mortality. And what are the what are the gaps in the malaria case management compared with the WHO recommendation? The next part would be introduction of 24 hours initiative. And the third one would be the evidence supporting 24 hours initiative. So that is the article structure. And the importance of the article is that, and the initiative, we are going to introduce the initiative, is that it supports reduction of malaria mortality, and definitely reduction of malaria mortality is the first and important milestone in the pathway to Uganda free from malaria, Uganda free from malaria. That is the first one. And in the next strategic plan, 5 strategic paradigm shifts have been designed in the pathway to elimination. And 24 hours initiative, we believe, WHO and Ministry of Health, we believe that this is the starting point for a strategic paradigm shift. Most important strategic paradigm shift in the pathway to malaria elimination. And the next point that I wanted to highlight is that one of important strategic intervention that has been introduced in that initiative, 24 hours initiative, is community-based case management for malaria cases for all age group. And this is important because it helps resilience of the health system, and also it is also facilitate integration of diseases. For those 2 reasons, community-based case management for malaria and other communicable and non-communicable diseases is a strategic paradigm shift and is a dire need for Uganda. With that introduction, I would like to ask dear Dr. Morin to present to you 24 hours initiative, the most important strategic paradigm shift in the pathway to malaria elimination in Uganda. Thank you.
Thank you very much, Dr. Mansour. Among the drivers that of resistance, we hope that this will also be a game changer if we are able to delay the resistance, but also manage most of the drivers which are within the community, but also at the facility. So the 24-2 initiative is a program that, as Dr. Mansour has noted, co-joint with WHO, and we know that malaria is the largest contributor. And we have an average of about 6% of the malaria cases hospitalized in 2023, and that is nearly 3 times the global target. We also know that delayed treatment is a key driver of malaria mortality in Uganda, and according to the Malaria Indicator Survey, only 57% of children under 5 with fever sought treatment within 24 hours from the onset of fever. And these delays in starting injectable artesunate is a major contributor to mortality in severe malaria cases. And the key statistic is about 25%, that is 1 in 4 inpatients delayed to initiate hospital antimalarials by at least 1 calendar day. And this is a very big issue. This trial just emphasizes the timeliness of treatment as a critical but often neglected game changer in malaria case management. And here we are looking at from the time we suspect the malaria case, prompt seeking should be done within 24 hours. But we also see that once we have confirmed the uncomplicated case, treatment should be given within this period of time. So testing and treatment should be given within 24 hours. For a severe malaria case, if treatment is not available, pre-referral treatment should be given within the first 2 hours. And for actual treatment, once treatment is available in that center, we should be able to initiate our treatment for severe malaria within the first 2 hours. So this shows where we need to implement the 24-2-hour initiative and how we need to make sure we monitor, but also discharge our patients and be able to follow up to ensure that they can get their post-discharge malaria chemo prevention within 24 hours of discharge. So the expected results are really for us to ensure that these seek care within 24 hours, initiate treatment within that time for uncomplicated, but also for severe malaria, be able to provide this care within the first 2 hours of treatment. And we know that this is a very big changer, and we shall be able to reduce the progression to severe disease, but also prevent the patient from dying. And then the discharged malaria patient, as I've spoken about, to make sure that we have 50% of the children that are discharged from the hospital dying within the communities. So we need to be able to initiate the post-discharge malaria chemo prevention within 24 hours. So why this is very important, we know that mortality and the risk of death from severe malaria is greatest within these first 24 hours, and once we delay, then we have progression, increased complications, but also deaths. We know that this prompt treatment also has a role in cutting transmission, because we know the PFAS, paramgametocyte maturation within the bone marrow, takes about 10 to 12 days, and on average 14 days. So if we do not initiate this treatment early, then we are also contributing to transmission. So this 24-hour initiative has a key role that it's playing within cutting transmission. These are the expected outputs, and outcomes that we've mentioned earlier, and the number of, just to show you, a 50% reduction in malaria mortality, saving approximately 1,400 lives annually, and 80% reduction in severe malaria cases. So this is really an aspect that we should take on to make sure that we can be able to achieve these results. Why is this important? We know that it reduces the severe malaria rate, but also reduces the health system burden and the attributable deaths as a result of malaria, but also it reduces the out-of-pocket expenditures and consumption of these other blood transfusion and different elements that are required in management of severe malaria, but also prevent the spread of anti-malaria drug resistance, enhance equity, the economic loss that I've spoken about, as well as reducing the transmission intensity. So in conclusion, this really is able, if it's applicable to if it's applied to high endemic regions, including sub-Saharan Africa, then we should be able to adopt it to our local context and achieve the results, since we know that the program in the next 5 years is looking towards elimination of malaria. We also encourage operational research in that fora to be able to understand and measure the impact of the 24-hour initiative. So we acknowledge this. Thank you very much for listening to us.
I thank you very much, Dr. Maureen. Please, another round of applause. It was, particularly for keeping within time and delivering a solution. Our next presenter is Thomas Katairo. Are you here? Thomas, yes, get closer. Thomas will be presenting. Can we have Thomas Katairo's presentation up, please? The title of Thomas's presentation is Geographical Distribution and Temporal Trends of Antimalarial Drug Resistance Markers. It's online. So this is move. The position is important. Okay, and then forward, back. This is forward, back. Okay, you have 8 minutes. Thank you.
Good afternoon, everyone. My name is Thomas Katairo, and I'm going to present about the geographical distribution and the temporal trends of the antimalarial drug resistance markers in Uganda. This is for the 4 rounds of sample collection in the year of 2023 and 2024. So just as background, Uganda, we know that has the 3rd highest malaria cases burden globally, but almost everyone in Uganda is actually at risk of malaria. Malaria is highly heterogeneous. If you look at that map, you can see how widely distributed, with some regions having very high prevalences and others very low prevalences. But in order to curb this burden, we are using different antimalarials to do this. For example, we're using artemether-lumefantrine as our first line of treatment, then dihydroartemisinin piperacin, which is DP, as second line. But if you go to different facilities, you'll find other antimalarials. For example, artesunate amodiaquine and artesunate pyronaridine, which are used as alternative treatments. Just like we heard from the previous presenter, they will do, the Ministry of Health actually recommends IV artesunate, followed by oral ACTs for severe malaria. But then we are using other antimalarials like sulfadoxine pyrimethamine for intermittent preventive therapy in pregnancy, and also sulfadoxine pyrimethamine with amodiaquine for seasonal malaria chemoprevention that is actually in Karamoja. So in this, we wanted to determine the key polymorphisms that are associated with the drug resistance across 4 rounds in sample collection between 2023 and 2024. For this, we used dry blood spots that were collected from symptomatically individuals, patients that were 6 months and above of age, and these had to have uncomplicated malaria that was microscopically confirmed. We did the DNA extraction, we used a method called Chilex, and for library preparation, we used an amplicon targeted sequencing method called MadHatter. We used Illumina, a platform for sequencing, and then the bioinformatics, we used the AMSEC platform. So on my right, you can see the map and how widely spread our samples came from. So we tried to cover the whole of Uganda to see a picture of Uganda. Of interest are the 3 districts that are in the southwestern Uganda that have like diamonds in black. Those are what we refer to as low transmission sites. These ones tend to have very low parasite, very low malaria. And as you heard from the previous presenter, this is an area that they are considering for malaria elimination. So we wanted to see what's happening here. So I wanted to give a brief introduction of what we have been seeing. We have done this project from 2016 up to right now. From this, and this is a map that's showing the mutations that are associated with artemisinin partial resistance, which is one of the antimalarials we use, the artemisinins. So in this, we noticed that the mutations of the K13 have been associated with partial resistance. And in Uganda, we tend to have 5 mutations that are in Uganda, and 3 of these are validated by WHO, but 2 are candidate markers. 2 of these mutations, the 469Y and the 675V, are mainly seen in the north if you see the upper 2 maps. But what is interesting is these are spreading at higher prevalences if you look at the 2024 map compared to the 2016 map. But of interest is the other mutations like the 441L that is actually being seen on the border with DRC, 561H, which is seen in the low transmission sites in the southwestern Uganda, and the 469F that is also seen in the same area. So for the 2 rounds, the 4 rounds that we had, this is what we are seeing. From these maps on the x-axis, these are the sites where we collected samples from, and on the y-axis is the prevalence. You can see different patterns of colors. The green, these are different mutations that are being detected. And of interest is that you see in the north, northwest, east, and the northwest, they tend to have a green and a blue color, which these mutations, which is the 469Y and the 675V. So they are predominant in that area. But then if you look on my right, there are those ones that have more of the pinkish color. These tend to be localized in the western parts. So that is the west and southwest. So from this, we see that the prevalence of the 469Y and the 675V have plateaued from what we have seen from the previous map, and it seems they are getting into fixation. I mean, they're not going to go into fixation as earlier anticipated, but in the north and the east, we see that there are some samples that tend to have a mix of more than 1 K13. So samples tend to have more than 1 K13 mutation. In the west, it seems that all the 5 mutations are circulating, and there is no clear pattern trend. But of interest is that the 441L seems to be more abundant in these areas. So when we look at other mutations, especially in the aminoquinolines, where chloroquine, amodiaquine, piperacin tend to fall, polymorphisms in the polymorphisms in transporter genes are the ones associated with resistance in these in these drugs. Mainly of interest is the CRT-76T, which was confirmed to confer resistance to chloroquine. But there is also the MGR86Y and 1246Y that are associated with chloroquine. Generally, the prevalence of these mutations is actually reducing over time. And by 2023, we are seeing an increased prevalence of the 76T and the CRT97L in the northwestern Uganda, that is the West Nile, if you look at the map very closely. But this is not being seen in any region apart from those two. So this is the same thing that is showing that these tend to have prevalences of up to 50%, which is something we have not seen in Uganda. It's just popping up. And when we look at the ones that tend to look at folate resistance, that is for the ones for people that do intermittent preventive therapy, we realize that the one that we are interested in is the 164L and the 581G, which confer high resistance to SP. These are mainly seen in the southwestern Uganda, which is the low endemic area, but then the 164L tends to increase in prevalence when you're going towards the east. But these prevalences are very low for the northern parts of Uganda. And this is the same thing we are seeing from the graphs. So maybe to conclude on this is, in Uganda, we have 5 K13 mutations that are prevalent, and these tend to be different for the different regions. There seems to be a plateauing in the prevalence of these mutations, though we had thought it would increase to fixation at a certain point, but that's not what we're seeing. Some samples carry more than 1 K13 mutations. The CRT-76T and 97L that are associated with chloroquine resistance and amodiaquine tend to be at low prevalences, except for the northwestern Uganda. The quintuple and folate mutations are almost fixed in Uganda. And parasites, in conclusion, parasites in Uganda are becoming more resistant to available antimalarials. So for the study implications, we need to continue tracking the different polymorphisms associated with antimalarial drug resistance, but we also need to do more studies, for example, therapeutic efficacy studies, lab-based studies to see the implication of these mutations on drug efficacy. Thank you very much.
Another round of applause, please. Our next presenter is Dr. Robert Namis Masamba. Please get closer as we ask the IT team to put up the slide. The title of Robert's presentation, Establishment of an Antibiogram Profiling System to Strengthen Antimicrobial Stewardship at General Military Hospital, Bombo. And yeah, IT. So Robert, you have 8 minutes as we wait.
Greetings to you all. I'm Robert Namis Masamba, a Laboratory Leadership Fellow at Uganda National Institute of Public Health. I will be presenting to you results of antibiotic profiling system to strengthen antimicrobial stewardship at General Military Hospital, Bombo. An antibiotic profiling system is a structured digital framework that continually collects, analyzes, and reports on how bacterial isolates respond to different antibiotics. World Health Organization Global Antimicrobial Resistance and Use Surveillance System recommends that countries, including Uganda, should use the available data, microbiology data, to create an antibiogram for local and national use. An antibiogram is a summary report that shows the percentages of how isolates react to different drugs. It is presented in a table form with isolates in the rows and drugs in columns with their percentages. It is based on antimicrobial susceptibility data for a particular health facility, and the antibiogram guides empirical treatment, which improves patients' outcome as well as guiding antimicrobial stewardship. An antibiotic profiling system is a summary report. Okay. That is, no, it was this one behind. Okay. Okay. An antibiogram is a summary report that shows the percentage of bacterial isolates susceptible to different antibiotics in a defined period, usually of 1 year. It is presented in tables and it shows different drugs, how they act on different organisms. An antibiogram is a summary report of the percentages of how drugs work on different organisms. Now, antimicrobial stewardship is a guide on how different drugs should be used basing on the strategies laid on the ground to make sure those programs are followed so that drugs are used properly. Now, in April 2024, while reviewing data in the facility, it was realized that most of the patients who are getting empirical treatment against UTIs were not responding. This is because there was no structured program to ensure that we have an antibiogram which guides the treatment, and that gave the ground or the basis to have an antibiogram. We set out to establish an antibiogram by mentoring health workers on the principles of how to collect the data, analyze, and make the reports. General Military Hospital Bombo is the national referral hospital for Uganda People's Defenses. It is located 34 kilometers along Kampala Gulu Highway, provides healthcare services both soldiers and civilians, and currently the only facility doing culture and sensitivity. To secure part of the work we did was engaging the stakeholders, as you can see in the photo, to get their buy-in and then get those to be trained. In this photo, it's showing how I was mentoring the staffs on data entry in an Excel sheet. So we developed the antibiogram by collecting the data, extracting it from the registers, and cleaning, analyzing. Ladies and gentlemen, allow me to share with you the outcomes of the study. Different health workers were trained with the largest number from the laboratory because they are the ones who are critical in conducting susceptibility testing and analyzing. This is a snapshot of an antibiogram which was developed. We recommended that we conclude that having an antibiogram is key in antimicrobial stewardship. We recommend UPDF Health Services to continue support supervision of this work so that the antibiogram is sustainable and updated periodically. Recognize the following institutions. Thank you.
Yes, Wanyala Navi, Mr. Namisi, for very interesting slides and also for keeping within time. A round of applause, please. Our next presenter is Dr. James Kapisi, and the title of his work, please move closer, is Comparison of Community and Hospital Antimicrobial Use Practice, Susceptibility and Resistance, and Determinants of Care Seeking Among Patients with UTI in Kampala. James will take 30 minutes to introduce, 30 seconds to introduce himself and take us through the slides. Red, green is front, red is back. Positioning.
Good afternoon, ladies and gentlemen. Good afternoon. Yeah, lunch is on the way. It's okay. My name is Dr. James Kapisi. I work at the Infectious Diseases Research Collaboration, IDRC, together with a couple of people who have presented here before. I want to take you through what we are doing in the community briefly. And I'm presenting this work on behalf of the CAST UTI study group and the affiliations as well, as you can see, Makerere University and City St. George's University of London. So the topic is, the title seems like a mouthful, but we are basically comparing community and hospital antibiotic use practices. We want to also compare resistance and susceptibility and determinants of care seeking among patients with uncomplicated urinary tract infections. Yeah. So a brief background, UTIs cause many infections around the world, and probably among the leading infections why we give antibiotics to so many people. And females get affected by this quite a bit more than men. Yeah. Okay. And almost 90% of the antibiotics that we give most people come from primary healthcare settings. And so that's where we went to study because of that. And in primary care settings, we know that we know for sure that most of the antibiotics are empirical, and we find that people get many multiple antibiotics at once. But the challenge is also that most of the data that we present, especially to GLASS, as someone mentioned here, is mostly from hospitals and not so much from primary care settings. So we want to see whether what is in the community is representative of what we see in the regional referrals that generate most of this data. So our main objective was to, as we said, investigate the causes, treatment, and outcomes of uncomplicated UTIs in patients attending community drug retail outlets, including drug shops, pharmacies, and clinics. And then later compare that with GLASS, which usually comes from hospitals. And then we have a number of secondary objectives where we want to describe the prescribing and dispensing patterns in those places. We want to see what kind of people go there, because we think all this has a bearing on AMR. What is their socioeconomic status? What is their illness? What is their demographic? Then we want to see the resistance that they carry in the urines, which are infected, but also in their stool, which is really the carriage strains. See whether they are linked to what is causing their UTIs. And so that's a summary of the study. I hope it is clear, but it's a summary. So we chose to study in Muwongo, which is and another neighborhood, Muyenga, stroke Bokassa, which have similar. So we want to compare an affluent area and one that is less affluent. But we are using a mixed method study. It involves social science work. It also involves collecting the. So as you can see, as you go down, we are collecting from 30 community drug retail outlets from each community, and also recruiting some patients from nearby hospitals, that is Naguru and Chisugu Health Center for comparison. And then later we shall also compare with GLASS. And what we quickly do, we start with the patient when they come to the CDRO complaining of symptoms that are like UTI. And then that's when we register them. We take information from them and then collect urine samples, which we do culture and sensitivity on. And later we shall do genomic sequencing to look for resistance. We also talk to them about the patient pathway, that is social science work, to get the contextual factors that lead them to why do they decide to go to these facilities, what is their experience there, to try and see what really drives antimicrobial resistance. So we are still collecting data. So our project is less than a year, and we've recruited 30 health workers, 60 CDROs. Okay, we are in also two hospitals, as I say, Chisugu Health Center 4 and also Naguru Regional Referral Hospitals. We've so far recruited 600 participants. Both they give us urine, and we also take a perianal swab to compare what they are carrying in their GI with what is in the urine. And also want to check what antibiotics we find in their urine before they take the drugs prescribed to them. And we check on them on 7 and 28 days to see the outcome of their illness. So I'm just going to give you some preliminary results, not the main, because we are still analyzing the data. But we found that the community has less positivity for UTIs compared to what is in the hospital, kind of. Then again, women are affected more, as you can see, and we are seeing a lot of E. coli, just like most people have shown here in the urine, but the AMR we are detecting is high. We are seeing a lot of ESBL, and ESBL, as we've noted there, means resistance to common penicillins and cephalosporins that we love so much, starting with the ceftriaxone. Again, we are seeing polypharmacy, as we noted in the literature. And then the winner is that we are struggling with is that even health workers who are trained, distinguishing between STIs and UTIs is still a big problem. And we think that is also driving the kind of antibiotics they are giving and the polypharmacy that we are seeing. So what are we beginning to understand the study implication is that mostly that we are seeing that we are learning the patient pathway of getting to treatment, especially in CDROs, and we want to give more information on that at a later date. We are learning the kind of workforce that is in these places, what is their training level, what are their motivations. It's interesting. We want to argue that point of care tests will be very beneficial in CDROs to increase the diagnostic capability of these places. We think that will drive AMR down. We are learning about how the cost of antibiotics affects decisions. And as I said, STIs and UTIs, we need to educate people more on the difference so that it reduces, because it contributes to the polypharmacy that we see. And we have also found that 40% of the patients who have given us urine before they get to these places, they already have antibiotics in their urine. So we thought we were in a primary care setting where people, that would be their first point to get medicine, but it is also interesting. So this is a big factor in how AMR spreads. Okay, thank you very much. I would like to acknowledge the people listed there as we continue to do this work. Thank you.
Thank you very much. A heavier hand clap, please, for that great presentation. Our next presentation is by Pius Mukisa. Please come closer as the IT team puts forward the slides. Pius will take 30 seconds to introduce himself. The title of the presentation is Evolving Prospects of Antimicrobial Use and Resistance Surveillance in Uganda, a Political Economy Analysis. IT, please. You can stand at the side. Yeah. So the green is forward and the blue is important. You have 8 minutes.
All right, good afternoon, everyone. Pius Mukisa is my name, and I'm presenting to you my work entitled The Evolving Prospects of Antibiotic Use and Resistance Surveillance in Uganda, which is a political economy analysis. So just to go through a little background, really multiple interventions have been listed in this fight towards antibiotic resistance, and these include surveillance, infection prevention and control, antimicrobial stewardship, research and innovation, then public awareness. So just to narrow down to surveillance, which is the gist of my work, surveillance really of antibiotic use and resistance is so essential in this fight against antibiotic resistance, since it helps us in the targeting of antimicrobial stewardship interventions. However, the challenges of antibiotic use surveillance in low and middle income countries, Uganda inclusive, include the lack of appropriate context-specific tools to conduct the antibiotic use surveillance, but also the limited funding for the surveillance activities. Yes, so here in the country, multiple efforts have really been made towards improving the surveillance of antibiotic use and resistance in the country. However, we feel that there is still some inadequacy in monitoring not only antibiotic use, but also antibiotic resistance. So most of our surveillance efforts currently are passive, and really they rely on the readiness of our health facilities, not only to provide microbiology services, but also to treat infections. So we are all much acquainted with the microbiology capacity of our facilities in Uganda. there is limited microbiology capacity, but also where we have microbiology services available in our facilities, they are not really fully utilized. When you look at our antibiotic resistance surveillance system in the country, it is laboratory sentinel site, and most of our sites, sentinel sites, microbiology laboratories of regional referral, and at most district level facilities are really neglecting the lower level facilities, the primary healthcare facilities, where a lot of antibiotic use happens. So antibiotic use also really majorly happens at higher level facilities. So most of the efforts, when you look at most of the efforts around surveillance of antibiotic use and resistance, they are always technical, focusing on adaptation of surveillance approaches, adaptation of new tools, and improving the surveillance infrastructure. So few efforts actually are targeted towards the need to understand the political and economic dynamics that actually eventually influence the adoption, implementation, and scale up of the adapted and introduced interventions. So we aim to examine the positions, the interests, and the incentives of the stakeholders that are currently involved in the implementation of antibiotic use and resistance surveillance in the country. So we want to understand which actors are actually involved in the surveillance of antibiotic use and resistance in the country. Are there power imbalances? Who has the most power when it comes to surveillance of antibiotic use and resistance? Are there groups that are actually currently excluded out of the surveillance table that could be so important in surveillance? We want to understand the interests of these different actors. Why are they interested? What do they lose, or what do they benefit from participating in our surveillance? And also we want to understand their positions on the current surveillance approaches, their ideas, but also the formal and informal roles in the game of surveillance. So this is what we are asking. We are asking that what are the positions, what are the interests, what are the incentives of stakeholders that are involved in the implementation of antibiotic use and resistance surveillance in the country. So we have adopted a problem-driven framework for political economy analysis, and it majorly asks only 3 questions that I'm summarizing. The first question: what is the problem at hand? The problem at hand, we are saying that there is inadequate surveillance of antibiotic use and resistance. Then the second step of this framework is problem diagnosis, where we break it into 2. We have a structural diagnosis and then agent diagnosis. In the structural diagnosis, we look at the context and the institutions. What are the relevant structural features that actually influence the surveillance of antibiotic use and resistance in Uganda? Then what are the formal and informal rules of the game of surveillance in the country? So these may be plans, guidelines, but where there are weak links and there are powers in their implementations, then what further guides the surveillance of use and resistance? So on the other hand of agent diagnosis, we are looking at power. Who has the power? Who does what? Who has most power? Who has the least power? What are the incentives for the actors that are involved in surveillance of antibiotic use and resistance? What are their motivations? Are they financial? Are they political? Are they ideational? And then also the relationships between the actors. So just to summarize the methods, this is really an ongoing study. It's an exploratory descriptive study, and we are targeting antibiotic use and resistance surveillance stakeholders in the country, specifically those who are participating at the technical working groups, but also those who are active at the subcommittee meetings. So that is a simplicity of my study. Thank you so much.
Yes, indeed. Thank you very much, Pius, for keeping the time as well. Another round of applause for our presenters as they walk to the podium. Please, our presenters come and take seats and respond to some of the the burning questions from the audience. So we've had exciting presentations on surveillance of disease burden, focusing on anti-malaria drug resistance, geographical and temporal trends, bacterial resistance, focusing on organisms that cause UTI and some factors associated with that burden and treatment practices, determinants of how we survey by bias. So basically that the way we survey has some links to the political economy of the context. We've had two very exciting presentations on some of the solutions, the novel approach to surveillance based on lot quality assurance sampling, and another important potential solution, the 24-hour initiative to reduce mortality and transmission of malaria parasites, particularly under 5 children. So with those, let's take a few questions. Just remember that this session is between our lunch and between now and our lunch. So we'll be very brief. Your name and question, don't give us a preamble.
Thank you very much. I'll be very brief. My name is Edward Basenge from the Community Health Department. And this question goes to Dr. Maureen as she's preparing to sit. Community-based case management is very crucial strategy. And I know we are dealing with clinical response, but I'm a community person from Ruelo Triangle. We have what they call community health workers, and these ones focus themselves on home management. So community health workers can do a very great job in improving access to treatment and in reducing mortality.
The question, please.
So I request you to borrow a hand of this community intervention in part of your work. My second question goes to Dr. Kisipi. What are the current practices of antibiotic use in communities? Is it overuse or misuse? Is it self-medication, or is it incomplete treatment? Thank you.
Thank you very much. Let's take a couple more questions. The ladies too. So let's have the gentleman here. And the next should be a lady. So you move the mic to the lady raising her hand.
Thank you very much. First of all, mine is to...
Your name and question.
Matthias Mangeni. And I'm addressing Dr. Robert. The design is very interesting, but the entry point to enroll participants was facilities. Would you anticipate chances of compromising the quality of your intentions simply because those ones that are already going to high-risk facilities are already disciplined enough? And yet one of the key drivers of drug resistance is limited access to healthcare services and diagnostics. The other one is to my friend who gave us issues around mutations for the parasites. I want to know whether in your approach, you are also sensitive on issues of genetic diversity, climate, and then over-reliance to these insecticides. And in any way, would you be interested to compare, because we are now in a regional setup, would you be interested in exploring issues around the different approaches at regional level? Like, for instance, those that are along the borderlines, factors are that the other countries have...
I think your question is clear. Let's move to the next one. Two questions. The lady, yes.
Excuse me.
Your name and question, please.
My name is Dr. Faith Turia Jenda from one of the MDAs. My first question goes to Mr. Namisi. In your recommendations, you recommended that General Military Hospital Bombo considers utilizing a microbiogram in their other health facilities. My question, therefore, goes around, why are you having reservations? Why don't you want to generalize your findings? Is it that other health facilities within the country actually have a microbiogram in place? What was the reason for your reservations in generalizing your findings? Then my last question goes to Mr. James Kapisi. I find your findings a little bit contradictory when you say there were higher cases of UTIs in the hospital than in the community. And yet you say when you analyzed the urine from the community samples, there was evidence that antibiotics had been used. So I would imagine that is self-explanatory. People try polypharmacy. So the community was supposed to have less UTIs. Thank you.
Thank you. Let's next the gentleman there, and then we have our last question.
Thank you. My name is Emmanuel. My question goes to Dr. Robert Onzima about antibiotic. So you dealt on E. coli and what? The organisms you dealt with, as far as I know, those organisms are normal flora in the gut. So the participants that you sampled, were they patients or you were just picking anybody? Because these organisms are already normal flora in the gut, in the stomach. Thank you.
Thank you. We have the lady in yellow, and then the lady at the front as the last person.
Good afternoon, everyone. I'm Esther, and my concern goes to Mr. Kapisi. Maybe just to have clarification on what kind of organisms were got as per sample type. And then this would inform the conclusion of having more E. coli for us to see, is it more from the urine or is it more from the annual swabs? Thank you.
Thank you. And then our last question, name and question, please.
Thank you so much. Martha Nakaye. My question goes to Dr. Kapisi. You talked about the 40% positivity rate. Most of the patients had antibiotics in their urine. I'm just curious to know what kind of antibiotics had they taken prior. Thank you.
Yes, thank you very much. And I want to I take the last question to the refugee resistance among refugees. Do your studies show that the resistance patterns among refugees are different from the general population? Or do you think that that's something that needs to be investigated, and what would be the implications for that? So colleagues, let's have responses from the panelists, starting with Maureen on my immediate left. And
Thank you very much, Basenge. That's true. We all agree that community is where the work needs to be done. And you know that for the couple of times that we have, for the couple of years that we've implemented integrated community case management, it's been more around prevention of the disease. But for those that actually are not able, that cross over to care, they should be able to receive the care. And we know that ICCM still brings this care closer to the home, in the communities, to children under 5. And we've had discussions to increase the age group so that we're able to reach a bigger population in the communities, so that we're able to have them still identify, recognize, because the first delay is the recognition of the symptoms, signs within the community within the 24 hours. So if this can be extended to that age group, we believe that we should be able to reduce that first delay. And then the second delay, which is reaching the appropriate area for support. And then the third, which is basically receiving the treatment. So we believe that these still work both, yes, at the community, and then the treatment arm caters for the third delay. Thank you.
Thank you very much. I will move on to our next presenter. I just use the mic next to you.
Thank you. So I'm just going to answer the question about genetic diversity, use of insecticides, and climate change. Yes, we are looking into this. We actually find that areas that have high transmission areas tend to have a lot of genetic diversity compared to the low transmission sites. And it's something we are trying to trigger out in our analysis. We didn't have time to do all that. And then for insecticides, yes, we are also considering things like insecticide residual spray, which is IRS. So these are things we are trying to put them there, but because of the time, we couldn't present all this. But we can have a chat outside this to have more about this. Thank you.
Yes, thank you very much. Moving on to Francis.
Yeah, my question was about the difference in the patterns. Yes, they were different. Just because of time, we couldn't put that comparison, but we made the comparison and it shows that there were different patterns between the mutations.
Yes. So the burden of malaria, anti-malaria resistance markers among refugee populations are different from the general population. And why do you think that is important to find out?
Well, it guides on the drug regimens and more of control, how we're going to control.
Excellent. Moving on to Dr. Robert Onzima.
Thank you, Chair. I have two questions. First coming from Mr. Mangeni, who asked why health facilities, and isn't that a biased sample? I think generally we are trying to develop a surveillance metric that can be used across the divide for population-based surveillance of antimicrobial resistance. But the major reason we use the health facilities as basis in this study was that we also have an additional objective that looks at ascertaining the association between quality of healthcare and antimicrobial resistance. So because of that is the reason we focused on the health facilities as basis for sampling our participants. However, once we test the approach and it's validated, then it can be reliably used in community-based surveys for population-level surveillance at households. And further, much as we sampled in our facilities, we capture the location where these participants are coming from. And one thing I didn't present is we are also going as far as doing a spatial analysis of distribution of AMR using samples that we picked from these children, but linking it to the villages from which they came. In addition to that, we also have an approach to assess at community level using a household survey based on classical LQAS, drivers of antibiotic use and antimicrobial resistance at community level using mixed methods approach. Question 2 was related to focusing on E. coli and Klebsiella pneumonia, which are normal flora in the gut. Were the participants patients or not? My answer will be yes and no. Why I'm saying yes is we sampled children who are sick, presenting to health facilities with fever. And so they were patients. However, it is a no because the symptom these children presented with at the facilities was not necessarily related to the bacteria that we targeted, simply because we are targeting carriage of these bacteria, not necessarily related to the symptoms with which they presented. Being normal flora, yes. However, we are focusing on extended spectrum beta lactamase producing E. coli, extended spectrum beta lactamase producing Klebsiella pneumonia. Now, those are extreme forms of these normal flora which have acquired resistance to high-level antibiotics, including third-generation cephalosporins. Thank you.
Thank you very much. Moving on to Pius. Did you have a question? No. Okay, we'll move to James, who had several questions. Please keep it brief.
Yeah, there are only 4. What are the current practices in the community? Thank you very much. That's a huge question. It really depends on where you're operating. What we have as community is really drug shops, where we saw that the majority of patients just walk in with their symptoms and then ask for drugs, which is not new, this is known. And in the clinics, and also in the pharmacies, but in the clinics where you have some kind of health worker prescribing, you get a prescription that is generated from there. But what I wanted to say about this is that I think the most interesting thing is now the why, and that's what we are digging in, the contextual factors that lead to all this, depending on the community. So we will give more information as we publish this data, but it's rich, interesting data. But thank you very much. About contradictory information, yes, as a point of clarification, we must consider that you said it is obvious that if I go to that in the hospital, there are more, there is a more prevalence of UTIs than in what we categorize as the community, but that might not necessarily be the issue, because in our context, we must consider that we were only looking at uncomplicated UTIs. So we don't have complicated UTIs in ours. We don't have that. Then we must also ask ourselves, did we capture all patients with UTIs who come to these facilities? The obvious answer is a no. There are those who are not willing to participate. There are those that probably we are not called to review, and so on and so forth. So we shall need to interrogate the data to get more of this. It doesn't necessarily mean from our data that there is less in the community, not necessarily. We need to get more context around what kind of participants we recruited. And and we are collecting this data. How many people in this CDRO come and have a UTI vis-a-vis what we have in the study? It will be important for the analysis. I hope that helps. The last 2 are a bit easy. What organisms per sample? Urine, and comparing with we are still doing this analysis. So what I presented is in the urine, and we shall soon compare with what is in the stool, the carriage samples, and I will let you know. This information will be disseminated, but thank you very much. And what kind of antibiotics did we find in the 40% before they were treated? We've just done a preliminary that just shows that there are antibiotics in there, but we haven't gone into which antibiotics. It requires a little bit of more analysis. But again, since we said we are still collecting data, by next year, all this data should be out. Thank you very much.
Thank you very much, James, for those precise responses to the questions. Let's hear from Namisi, who had one very exciting question about the antibiograms. Please.
Yeah, thanks very much for the question. It gives me an opportunity to expound about the General Military Hospital, Bombo. You are specific, why is it limited to UPDF health services? Currently, it is where the gap has been. Remember, General Military Hospital, Bombo is the National Referral Hospital for UPDF. So all these facilities refer to Bombo. Now, when we give this information to them, they will use, and it may even reduce the numbers of referrals to the General Military Hospital. Otherwise, General Military Hospital Bombo as a facility under health is subject to supervision by Ministry of Health. So this information generated is for public use. Anyone can use. Anyone who needs support to create an antibiogram, it is doable. We are open to support. And by the way, from this work, according to data, 96% of the patients who were involved in that period of study were civilians. But on general terms, General Military Hospital Bombo receives 75% of the patients are civilians. It is open to everybody, and the information is open for public use. Thank you.
Thank you very much, Mr. Namisi. A round of applause for our panel, our presenters. I think what have we learned from this session? As I summarize, I request the presenter on insurance, you'll have 2 minutes to summarize your remarks to the audience. We are coming to the conclusion of this session. The presenters will stay here for a photo after. And those who want to join can join, otherwise we'll break for lunch. So what have we learned from this session? That resistance to our common treatments is present, it is increasing, focusing on malaria parasites, which we know malaria explains or is responsible for up to 50% of our disease burden, at least from the data in our health facilities, both inpatient, but more so outpatient. So we need to do something. We need to ensure that patients with malaria are tested, are treated, and if they're given medicines, they should complete the dose. But we also need to adhere to the Ministry of Health guidelines on preventing these transmissions. If there's no infection, then there's no chance for resistance to develop. We also know that for bacterial AMR, it's also present. It is affecting our patients, and from the latest data, if we had to use some crude modeling, about 2 patients in our regional referrals die every day because of AMR-related illnesses. So we need to also do something. The drivers, as you've heard from the panelists among us, we need to reduce them. We also have solutions for the colleagues who work in health facilities using the antibiogram to power antimicrobial stewardship. We have solutions for surveillance in terms of improving the data that we have. And then we need to understand other factors that influence how we do surveillance, but also how we respond to the data that we have. So with that, thank you very much, and clap for yourselves for being a very good audience. And hopefully, as we move out of here, we are going to wash our hands to prevent infection transmission, but also adhere to the doctor's prescriptions when we are treated for infections. So please, the colleague from insurance, the floor is yours. 2 minutes before we break for lunch. And the panel will take a picture before that. Thank you so much.
Good afternoon, ladies and gentlemen. I'm called Prosi Chimboa from Prudential Insurance. Okay. I'm called Prosi Chimboa from Prudential Assurance. But for today, right now, I am here to enlighten us about insurance and health. I was meant to understand that in the session in the morning, there was a lot of questions about why health insurance is expensive. And maybe I would want to help ourselves, the insurer and the medical service providers. We at our desk as insurers are continuously finding it hard to service or to work with medical facilities. Why? Because there's a lot of fraud. There's a lot of medical fraud, when it comes to insurance patients. And if we can address this, health insurance will be very, very cheap. I want to give you a scenario this morning, no, actually yesterday morning. I went to access treatment when I felt some malaria, and I asked for my bill. They had given me an injection and a few tests, and the bill was 210,000. Okay? Then I told the gentleman, please make that bill cheap. And he told me, you see, I'm giving you injections and then tablets. I told him, okay, take off your tablets and give me the tablets only. I mean, take off the injections and give me the tablets. And the bill came to 62,000. This is live example. Then I sat down and wondered, I have done tests and he has given me tablets and an injection. The bill reduced to 62,000, meaning the cutoff was 150,000. I am wondering, was each injection 75,000? You get what we're saying? So even the medical, I even want to go back and tell him that, you know what, if I want an injection alone, how much does it cost for me to establish how far this person wanted to cheat? Because if it is 62,000, what was the cost of the injection? You get it? And it was malaria. So you can see how the practitioners we are also making it very hard to have treatment cheaper. Now, when it comes to the insurer, we have taken it upon the medical facilities. It is becoming very hard. The moment one enters and they say insurance, what was for 20,000 becomes 50,000. If only we can work with the insurer, we shall have treatment readily accessible. You get it? So if we can find a way of balancing these things, insurance is not expensive. We, the users and the service providers, actually make it very expensive and complicated. There's a lot of medical fraud. If you go to IRA, the Regulator of Insurance, you'll find this information there. Liberty, at the mid of this year, exited the medical market. You get, because the service has become more complicated for them. It is not profitable. People are doing all sorts of things. So let us try to balance how we manage our medical facilities with the clients that come in, so that even the insurer finds a profitable ground to operate. I thank you so much. I believe we shall have more time to interact and get more information on this. Thank you so much.
Thank you very much. Lunch, we have to get some time off our lunch time. So the next sessions will start at 2:15. So the lunch time has reduced from 1 hour to about 35 minutes. And I think that is a noble cause. In the afternoon, we have outbreak sessions. I'll ask IT to just screen them so that members can go for lunch knowing where they should go. So we have in Victoria Hall a session on tuberculosis, and then we have a break to view the posters from our wonderful researchers, and then from 4 to 5:30 we have another panel session on integration of HIV services in chronic care. So with that, colleagues, thank you very much. I hope this has been an exciting session. We are going to have photos with the panel, but please, you go to your coupons while you're registering. By the powers entrusted upon me, I declare this panel session closed. Let's go for lunch. Thank you.
A bigger round of applause for the moderator, please.
Thank you.
Come. Binabati sibira wanji.
The future of trust in the Lord. Sickness is mental.